Welcome to Black Health Matters. I'm your host, Darryl Armistead. This is a Howard University Hospital transplant support group session led by Dr. Clive Callender, who is a noted transplant surgeon and professor of surgery at Howard University College of Medicine. Let's join today's session in progress.
On dating apps and mental health. And it's interesting because I noticed recently, I talked to some of my children and children's children, that many of the people who are getting married and dating finding their dates via dating apps, and not like used to be, but dating apps. And so when you are dealing with your children and grandchildren, it's a new way of dating that they have that relies often on dating apps. And so this is a kind of a new wave, and they talk about the ways in which it's good for you and the way in which it's not so good for you. I don't know if many of you have had interaction with your children and grandchildren, and the new way of dating. Any uh, any experiences?
Nope. Mm-mm. One of my students when I was teaching high school, junior high school, excuse me, came to me and she was very upset because somebody had approached her on the internet, and turned out it was it wasn't valid. It was a stalker. So there's all kind of security issues when you're dealing with the internet, unless it's a live, like FaceTime or something like that, or Zoom, where you can see the person and know who they are. If it's just by text, it could be anybody.
Yeah, well, it's interesting because I've seen a number of people who are married, and they asked him how did they meet, and they met on dating apps. And so that some of them have worked out very well and some haven't. So, but it's something that you need to be aware of because your children and grandchildren, that's the new way they're dating these days. So you need to be aware of it in terms of uh, the article gave advice as to how to identify who you want to date with, and what the criteria are and what you should and shouldn't ask for. And so this is something that uh, parents and grandparents will be dealing with that we didn't have to deal with in our generation. So it's food for thought.
Yes. Good morning, everyone. Um, this I'm not sure whether my son was on a dating app or just on the internet scrolling or whatever they do. I'm not that much of an internet user as far as in Facebook and all of that. But this was not even recent. This was back in the 1999 or 2000, something like that. But he met a young lady, and they eventually married. They stayed together maybe about 5 years, but he met her online and they, interacted, and he married. And I guess the good thing that happened about it is we're in DC and this young lady lived in Atlanta, and he moved to Atlanta, where he still is today.
Uh,
And so he got that. He probably never would have left the area other than that. But she's a nice person. I still communicate with her, even though they've been separated. They're still married. They aren't divorced yet. But, um, you know, so I guess it's just how you interact and who you meet. But I don't really think he was on an app. I think he was just I don't know how you do it. I don't really think he was on a dating app. He could have been, but I don't think so.
But it's a new wave, so you just need to be aware of it and sensitive to the fact that this is the way that a lot of people wind up dating and getting married. And used to be you meet them in the church and other social events. Now it's
Met my husband at work.
yeah, okay, they work too.
Work. Mhm.
Yeah. Mhm. Okay, we can start with the articles. There's an interesting article which I would never have thought to read, which says that musicians face lasting side effects after breast cancer treatment. And it seems as though they're talking about men and women, but mostly women. But it was amazing whether they were instrumentalists or singers that the chemotherapy and other breast cancer treatment uh, affected their ability to be musicians. And this is something that this article recently published identified as that they did a musical toxicity questionnaire to find out, and they found out that 1 out of 3 identified as musicians, and 50% had difficulty because of inability to function as a musician because of the chemotherapy and the toxicity of the medications. It's something that I had never heard of before. And this study revealed that the impact of chemotherapy as well as the surgery itself uh, uh, was very impactful in terms of decreasing the ability of the musicians to be musicians. This is any of you musicians aware of the impact of the impact of chemotherapy and breast cancer treatment on your ability to function as a musician? No comment, so I guess nobody's had that experience. But anyway, this is a paper that identifies the fact that there is a negative impact and that we have to be very careful and recognize that musicians, whether they're singers or instrumentalists. Uh, John Buchanan?
Yes, I was wondering, good morning, everyone. I was just wondering if there was any uh, possible relationship with other cancer treatments, not just breast cancer, but just the radiation and the chemotherapy that you might have to go through.
This is the first article I've seen on this, so I don't know of any other article. That's interesting that all they talked about was the breast cancer. I don't know if there have been other studies on other cancers. Okay, well, let's go to the next article.
Before we go to the next article, um, men also get breast cancer sometimes. So this article will affect everyone, every musician.
Right. Okay, Lucille?
And I guess that's why it's so important for us to be part of clinical trials and get involved in research. Because I'm just hearing that we know how important music and the arts are to longevity, to all the things that take away stress. So it sounds like there's a connection some way shape, or form with something hormonal that's going on during the process of chemotherapy. Just a thought. And a thought that how important it is for us to be involved in the research.
Thank you for sharing. Let's go to the next article then. There's an interesting article that says that the site that you got vaccinated in is a site that gives you a faster immune response. You could have a response within a week or two with if you had the vaccination done at the same site that you had before, whereas otherwise it may take more than a couple of weeks before the immunity is there. So keep in mind that so when you get vaccinated, you get vaccinated in the same arm you had the last time, and that studies now identify that the immune responsiveness is faster because of the lymph nodes on the site where the vaccination occurred initially. This is surprising finding that I would never have guessed. Any comments? And they talk about how they did studies to identify and track how the memory cells moved and how within a week after the dose on the same side, there was immune responsiveness, whereas on the other side, it took more than weeks and in some instances about a month before you had the real immunity. So let's keep in mind. So remember the side you got the vaccination on the first time. So uh, recognizing that you get a faster response the second time.
Uh, yes, Dr. Callender, was there any study as to the strength of the response?
Yes,
We just
yes.
talked about the
Just the rapidity of the response.
rapidity, right?
Just the rapidity of the response.
But not the strength.
And that would make a difference uh, because sometimes it takes a month for the immunity to manifest itself, uh, but the strength of the response eventually is the same, but the rapidity to which you respond to it is faster.
Yes, Dr. Callender. When my husband and I go to our pharmacist, they have the chair there, and one side is against the wall, so he can only get to one arm. So that's the arm we always get our shots in. So I'm wondering if that's why it's placed that way.
I don't know why it's placed that way, but that works out well. Yeah.
Dr. Callender,
Yes.
another question. Um, which arm is better for blood pressure reading? And some people are of the opinion that it's best to get your blood pressure checked in the arm that's closest to your heart.
Doesn't matter. Doesn't matter. Been no studies that demonstrate it makes a difference. Okay, next article, please. This is an interesting article. One of the things that is interesting is that the nuts are such a source of protein and fiber, and they're comparing almonds and pistachios, and both of them are good. And you look at the values, and they're about the same, essentially the same, maybe a little bit more one of almonds over pistachios, but they're essentially the same. And so one of the bottom lines is that for fiber, there's probably not too many things quite like nuts. And the fact that they also have a great source of vitamin E for almonds is beneficial as well. But there's another article that talks about for gut health, one of the greatest things for fiber and protein is peanuts. So it's a welcome source of protein. It's interesting to keep in mind that this is a rich source of protein as well and fiber, both of which you need very much. Any comments on the role of nuts in our health and diet?
Dr. Callender, I like not pistachios. I like cashews. I, I do eat pistachios as well, but my favorite nut is the cashew. So I'm gonna put that out there for Darryl to check out.
Well, they say that if you look at nuts, cashews is not one of the top ones, although walnuts and uh, other nuts are thought of. Darryl, you want to make a comment? Can't hear you, Darryl. Can't hear you. Darryl, can't hear you. We can't hear you. We can't hear you.
You're muted.
You're muted. We can't hear you.
Yeah, he's been eating too many nuts.
Okay. Sorry about that. Any other comments on nuts? There's a variety of nuts, but it's 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 uh, it's interesting the way in which nuts can play a role in helping you have good bowel movements as well as giving you enough protein.
Is-
Janice?
Yes, it's interesting. I was talking to a friend of mine last night, and she's been having difficulty sleeping and some other health issues, and she was taking melatonin. She said, I think I better leave that alone. Now I can tell her to try pistachios and the fact that it's high in fiber, which is what her doctor told her, one of the things that she needs to do. So, again, good information. I can pass this on. And I love nuts. I eat all kinds of nuts, especially pistachios. Mhm.
Okay. All
Mhm.
right.
Dr. Callender, what about nuts with just regular peanuts, salted nuts? Are they?
Well, you just the only thing was they're peanuts, but the salt in them
It's what's
is what is the problem. But peanuts are okay.
it's
All
kind
kinds
of
of peanuts are
Check.
okay. It's just that when you talk about uh, the ones which have the most fiber and the one that have the most protein. Darryl, we didn't hear anything you said before.
Okay.
We
Can
can
you
hear
hear
you
me
now.
now?
Yeah.
Yeah.
All right. I'm getting an echo on my end. But anyway, let's see. Cashews, almonds, they're man-made hybrids. Pistachios are not. So I put pistachios at the top of the list.
Okay. Anybody else want to share anything else on variety of nuts? Okay, let's go to the next article. And they mentioned the salted nuts are the ones that have a lot of sodium in them. So keep that in mind. And this is an article that says about the same thing that number one snack for better gut health are nuts. Of course, they prefer the unsalted and no sugar, but they say essentially the same thing. That nuts are the best snack for gut health.
Check.
Yeah. Any other comments on this subject?
Why I think nuts that have no salt cost more than nuts that have salt. Am I correct? Which,
I have no idea.
okay, because it doesn't seem to make any sense for not to add salt costs more money than to add salt.
I have no idea. Anybody have any idea? I have no idea. Uh,
A lot of times they roast it, the ones that really don't have salt. So that that might be why. I don't know.
I had a quick question. Anybody know what edamame is?
what?
It's the word at the top of the screen. Edamame.
Oh yeah, and the mama. I think Darryl, you made a comment about that once, but I don't know what kind of uh
It's
snack.
a soybean.
Yeah, soybean. Okay. All right. Thank you. Okay.
We should try to get this person on our meeting. Janice sounds like a sister too. She's a gastroenterologist in DC. We should try to get her to come on.
Okay. Let's go to the next article then.
Check.
What to call Moffat.
I'm not familiar with nut butter. Any of you out there familiar with nut butter?
It's just like peanut butter.
Oh, is that what it is? Oh, okay. Hmm.
They have cashew butter also.
Hmm.
I've had. It's good. I like it.
Yeah,
Okay.
cashew, butter, almond butter.
Okay.
Yeah, jelly and peanut butter sandwich.
That's what we grew up on. Yeah,
I did.
I did too. This is an article that is kind of scary in the sense that the leading cause of premature mortality in patients with mental illness
Mm,
is heart disease. And they say that if you look at, I don't know what happened. Yeah.
I'm sorry.
Good.
I'll get back. Hang on.
Uh, yeah, I was alarmed to find, let's go back to that article, to find that if you have uh, heart disease and you also have mental health issues, that the likelihood of you dying 15, 20 years shorter than those who don't have mental illness is kind of horrifying, suggesting that people with heart disease and mental health are less likely to be treated satisfactorily, and uh, suggesting that the role of the psychiatrist in the management of people with uh, heart disease and mental illness is not looked at very well. Lucy, you had a comment, Dr. Perez.
You're muted, Dr. Perez.
Can't hear you.
Hello?
Yeah, we
The
hear you now.
word, there's a book that I rely on, and it says, guard your heart.
Says what?
Guard your heart,
Well, yeah.
meaning the implications associated with mental illness and heart disease. So much of what can occur, having been a patient, is the emotional component. And this just verifies so much of what we've known. I think we're going to find that it is important for us to integrate mental wellness in every aspect of health.
Yes, but while that is true, and there's no argument about that, uh, the impact of it on the heart is even more profound, suggesting that they have not been merged, And so that the importance of identifying depression and anxiety in those people with heart disease becomes even more important. John Buchanan?
Yes, Dr. Callender, what are psychotropic drugs? What does that mean?
Those are drugs that help treat anxiety and depression. That's the psychotropic drugs. The drugs that they use to treat depression and anxiety, which apparently, as we're treating people with heart disease, we aren't merging the point that Dr. Perez is making is that they need to be merged, that you have to treat the whole patient, not just one aspect of the patient. Dr. Perez, you wanted to make some more comments?
The other comment being you don't know what came first, the chicken or the egg.
And it doesn't matter. You need to treat both.
You need to
Chicken and
treat
egg.
both.
Right.
But if we started earlier with the mental health component, could we prevent a lot of what we see in cardiovascular disease?
That's a question that we weren't aware of, but one thing is clear. If you got them together, you need to treat both. And treating one without the other apparently results in premature mortality. And so it's imperative that we as health providers become more sensitive to the mental health needs of our patients, particularly those with heart disease. But as you pointed out, and as the psychologist who presented to us pointed out, if you don't have mental health, you don't have health. Betty Blaylock?
Yes. Do you think that maybe sometimes doctors, because they see that the patient may have a mental health problem, they don't interact with them as much? They kind of shy away from them.
I don't have any evidence that that's the case. Because, but I don't know any evidence that that occurs. We certainly know it should not occur, but I don't know of any study that identifies that as a reason for doctors not to take care of people who have mental health issues as well as cardiac issues.
Okay.
I think there's a likelihood that the doctor may be less comfortable treating the mental aspect of it and treat only the heart issue without really treating the mental health issue, which is imperative to do so. This article emphasizes that that the price you pay is that the patient probably doesn't take the medicine appropriately, and therefore the likelihood of them dying more quickly is a consequence. John Tatum?
Yeah, I wonder whether a doctor, how a doctor could give a patient a referral to a psychiatrist or psychologist.
What is your question?
What would be the approach for a doctor to work with a patient and find out that the patient has a mental disorder and then give that patient a referral to a psychiatrist or psychologist?
That would be expected, right? That is what would be expected to occur. John Buchanan?
I'm sure all of the doctors
John
trained
Buchanan is next.
by
John Buchanan is next.
Yes, Dr. Callender, I was wondering that the cardiologists should know. I mean, I have several friends who had bypass surgery. They all went through a lot of depression, a lot of anxiety as a result of their surgeries. And this is the first time I've recognize it, but darn right, each one of them, suffered greatly, especially at first. I just had another one 2 months ago. He had bypass surgery. He's doing well now, but he went through a couple of months of very serious doubt and depression.
Well, I'm glad you mentioned that because Clint Walker has communicated with us with John Tatum and Buchanan. He's been on our group, and he had a heart attack. And what he recognized is there wasn't a group for people who have cardiac problems. And so he's in the process of starting a group patterned after ours for people who have heart disease to address this particular issue. Because he recognized that there was no group for people who have heart disease, and they need it as much as anybody else, as you're pointing out. And so we need to be of support for Clinton Walker as he tries to start a group kind of based upon what our group is being doing for kidney disease, is doing the same thing for heart disease. And this article points out that it is critical to be done. He's trying to get financial support for his group, and so I sent him our role model, and hopefully he will have a group in place soon. But your points are very well taken. This is especially critical for people with heart disease because they will often have the depression and anxiety that you mentioned. Any other comments about this?
I have one.
Yes.
That's why it is so critical to have teachers of doctors like Dr. Callender teaching them. Because I've heard surgeons all over this country speak that have gone through Dr. Callender's training that are better doctors because of him and his sensitivity to the patient. They want to be like him. That's why it's critical, not just because we are proud of Dr. Callender, but we have to maintain our institutions like Howard. We have to encourage Black boys to be physicians. It's on us. And it's like the Nick game and we're getting ready to lose. It requires all of us.
Touche, good point. And as the administration tries to eliminate diversity, we have to emphasize the merits and importance of increasing diversity. Uh, so, so it's an interesting battle that we will continue to wage. Okay, let's go to the next article, please. This is an interesting article that 40 to 63% of cardiac arrests, fatal in 90% of cases, can be avoided if we take care of obesity, diabetes, hypertension, and sedentary behavior. And as they looked at studying the Canadian Journal of Cardiology pointed out that if we were to address those issues, that we would reduce the number of people who have cardiac arrests. And it's an interesting hypothesis, like pie in the sky when you're looking at 56 variables. But when you look at physical activity, sleep duration, dietary habits, smoking, uh, then that would decrease the number of people who have cardiac arrest and the number of people who die from cardiac arrest. And this is something that is worthy of doing, but it's going to take concentrated effort. And of course, it implies that the things that we talk about are the things that need to be addressed. adapting healthy lifestyle, uh, having a healthy diet, uh, emphasizing vegetables, fruits, exercise, weightlifting, and as well as aerobic exercises. All of that goes into uh, decreasing the likelihood of heart disease and sudden cardiac arrest. Any comments on this observation that they made in the UK and Canada, but is just as appropriate here as well? And for the most part, that's what we've been talking about in our group as long as we've been around. So I guess it's important for us to continue to do it and to uh, be a role model for other groups to form to do the same thing all over the country. Because it's tough to beat a healthy lifestyle. Any comments about that? No comments about that? This is an article that talks about the fact that there's a medical way of handling cardiac arteriosclerosis and carotid artery stenosis. In the past, the treatment was surgical. And now optimized medical therapy is as effective as surgery. Therefore, the need for the surgery is less important. And so it's important for the doctors to be aware of it as well as the patients that there's so many diseases now that can be handled by medical therapy that can obviate the need for surgery. And this is just one of them. And this is important because if you have arteriosclerosis of the carotid artery, you're likely to get a stroke. And the prevention of the stroke is critical. I think there was someone who talked about the impact of a stroke on someone's health. And the prevention of a stroke is certainly much more important than managing the stroke itself. And in this case, the optimized medical therapy would prevent the need for surgical intervention and prevent the stroke. So this is something to keep in mind. As you know, the people over 60 are more likely to have high blood pressure and strokes than other people, and particularly people of color. So it's important to keep in mind that we're now in an era in which many issues can be handled by medical therapy as well as surgery, but in some instances, the medical therapy can replace the surgery. And this is an instance it's in this case. Any comments or questions about John Buchanan?
Yes, what is the form of the medical therapy?
Oh, the form of the therapy is keeping the blood pressure under control, keeping the diabetes under control, and usually this, when they follow the medication that is used, will prevent the need for the endarterectomy and prevent the need for a stroke.
And I have one more question. Right at the endarterectomy. What is that?
That's where you go into the blood vessel and remove the clot.
Oh, okay.
Because the clot, if it persists, will result in a stroke. And so one of the ways we used to do this is to go in and take out the clot and prevent the stroke. This is now saying that using medication is just as effective. Dr. Perez?
That's why access is so important. And we have to make sure that everybody in our community has the opportunity to have the access to quality health care.
Yeah, and of course, the thing about optimization of your medical therapy means you have to take your medicine. Uh, and that goes back to the point about the mental health, because people who are depressed aren't likely to take the medicine properly. If they're anxious, they may or may not take it. And so in those situations, uh, if they aren't taking the medicine, they probably would need to have the surgery.
And Doc, what is stenosis?
That's where you have a narrowing of the blood vessel.
Thank you.
And the narrowing may be because of the clotting of the arteriosclerosis of the carotid artery, which is the artery that takes blood to the brain. Carotid artery of the neck takes the blood to the brain. If there's no blood to the brain, you get a stroke or you die. Thank you for those questions to clarify, so you know what we're talking about. Okay, let's go to the next article, please. This is an interesting article because sudden cardiac arrest still occurs in young athletes, but what is really problematic is there's a reduced survival among Black athletes. And they talk about the fact that survival is improving in young athletes, but that it's still disproportionately higher in Black athletes. And they talk about most of the sudden death occurred during exertion, only 3% an hour after exertion and 16% after sleep. But and that the overall survival rate was 49%, but that when you looked at ethnic issues, the Black ethnic group, it's not a race anyway. Being Black is an ethnic group, not a race. But anyway, the people of Black ethnicity still were dying far higher than other ethnic groups. And we aren't sure why this occurred. And there's another article that talks more about what we can do to prepare our athletes so that they don't have a cardiac arrest. But it's important to know that we still have cardiac arrests among the young people, and there's a particular interest in Black athletes in particular. Any comments or questions about this interesting data? Well, now this is a spontaneous coronary artery dissection is something that happens with athletes who are extreme athletes. And this is a story of one who, in spite of his spontaneous coronary artery dissection, uh, continues to do extreme athletic endeavors in spite of being advised to stop. And this is one of the conditions that is perhaps caused by his extreme athletic endeavor. And it goes to show his doctor told him to stop, but he continues. And this is just something that happens. Yes, John?
What is dissection?
Okay. Spontaneous, it means that you have a situation in which your blood vessel uh, separates, and part of the internal wall is separated from the other part of the uh, blood vessel, and this is called a dissection. And what happens is the consequence of that you get a blockage of the artery, and you will have a heart attack. And uh, this is what this gentleman had, and it's often treated by medicine and by stopping the extreme activity that causes the dissection. So the blood is supposed to go directly into the lumen or the opening in the artery, but instead you get a tear in the blood vessel and the blood goes into the inner wall, and that blocks the circulation. And so one of the treatments is to stop the extreme exercise and to take blood pressure, take medicine that controls the blood pressure and makes the likelihood of the dissection becoming less of an issue. This I included because, again, here again, this is a cardiac condition which is associated with ventricular fibrillation, which means that you die if you're not defibrillated. And while medication, anticoagulants, and antihypertensives are the treatment, it's expected that you would also stop the extreme exercises. This particular patient refused to do so because he felt that this is part of his life. And so he's continuing on the anticoagulant therapy and has not changed his lifestyle. But it is recommended that if you have this condition, that you stop the extreme sports. And it brings into mind the new way that people are handling this situation. At one point, the cardiologists would stop people from doing it. Nowadays, they share the recommendations and then let the patients do what they feel that they want to do because it's their life. They have the right to live as they see fit. So anyway, this is just an example of a new way of dealing with things. There was a time when the cardiologists would say you have to stop this, and they would stop. But nowadays, it's the patient's right to do what they want to. It's their life, so they have the right to die as well as the right to live. Anyway, any comments or questions about that, philosophically or otherwise? Betty Blaylock?
Yes, I saw somewhere in the article that, about roller coasters. And I guess I've always had anxiety about going on a roller coaster. So I don't know whether I would have, I guess I was doing right by me because I definitely, my anxiety, and I've never liked roller coasters. I don't go on them. So
Yeah, I used to love them, but that was when I was 25 or 30.
I didn't love them then. I never loved them.
I agree with Betty. Why would you do something that makes you scared? Why? It's like a horror
It was
movie.
fun because it's fun. That's why. You don't understand that. But,
It's not fun.
well, that's the same reason why people ride bicycles, why they ride motorcycles, why they deep dive, why I do scuba diving.
Got me.
Yes. It's exciting. It's thrilling. And so that's why they do it. That's why this guy says, I'd rather continue. He said, I don't think it's going to kill me, but even though it will. he wants to do it anyway because it's thrilling.
It's like horror movies. Why do people like horror
Oh,
movies?
and they love horror
Yeah.
movies. It's amazing. I wouldn't I don't like them at all anymore. But there are people who love horror movies.
I'm with you, John. I don't like horror movies either.
So, it's the right of the person to decide if they continue to want to take roller coaster rides and all that stuff, you know.
Dr.
Like
Callender,
to
you
do it.
remember the cyclone?
Yeah, the cyclone, yeah. Yeah, I used to love those. Yeah. Yeah. Thrilling. Yeah. Darryl.
Yeah, it's adrenaline. It kicks in within seconds to minutes after a stressful event. So if you're doing any of those thrill-seeking adventures, you get that rush of adrenaline, and it feels good.
Yeah. Thank you for sharing. Uh, I remember we used to go with Motep to these race drivers, and it was amazing to me that they just love those high speeds, even though they have accidents and some die and some don't. But they just were addicted to that thrill of that adrenaline rush that he's talking about. They're addicted to that, and so continue to do it. You can't stop them. They just love it. Yeah. Okay, let's go to the next article. Now, this is something that actually Darryl talked about on occasion. The fact that sudden death in runners on the rise, but that's because you only have 1.5 sudden deaths per 100,000 athletes. But there's more and more athletes that are running now, and so you have more sudden deaths. But as this article and others show, that a lot of it depends upon the age. If they're under 35 or over 35, if they're overweight, if they smoke, if they alcohol, uh, if they have a sedentary lifestyle during the week followed by intense weekend sports, so that there are a number of things to do to try to reduce it even shorter. But this talks about having a stress test for people under 35 and uh, additional tests for people over 35 because the increase of the death rate is usually among those people who are older, who have arteriosclerosis and hypertension and other issues. And so it's recommended but not mandatory that you get these workups prior to running. Darryl?
Yeah, I've done 18 marathons, and I remember when I first started doing marathons, like the Chicago Marathon had 15,000 runners in about 1999. Currently, there's 50,000 runners out there, and it's more popular because when I started, it was more typical that you had people that were experienced runners. They did the training. Nowadays, you get people that don't do the training, they just get out there because it's popular. And so they're really not prepared. And, you can, it's a lot of stress. It's easy to get, to just die out there, suddenly die. And that's what's happening to people. It used to be that, typically, with most marathons, like every other marathon, somebody dies. Um, and the numbers just keep going up. Now with Chicago Marathon, recently you have two or three people that just suddenly die, and you see they got the emergency tents set up along the course just to be ready. It's not people around mile 20. They have a lot of problems, and so the tents are great to treat people. Not everybody that goes to the tent dies, but more of them are dying these days.
Yeah, they talk about the fact that they have defibrillators as well as people who do CPR, but And they say that most of the people who have the attacks are within view of the finish line. And so they have a lot of tents there and the defibrillators there to try to help, and that the success rate with resuscitating is better than it used to be. But as you mentioned, as the number of people increase in running, the number of people who die increase.
Darryl, what's the length of a marathon?
26.2 miles.
Wow. That's a lot.
Yeah, it is. You ran how many marathons, Darryl?
18.
Wow. Amazing. Okay, let's go to the next article. And this is an article that just says that now we're better at getting people to survive after marathons. That at one point it was 70% died, and now 70% survive. So we've come a long way, but as Darryl mentioned, the problem is we have many more people running, and we have a lot of older people running who are not in condition, and so uh, we're recovering more people who have arrests, but they still have a lot of people dying.
Dr. What is the cause of death from these runners?
Many of them have hypertrophic cardiomyopathy to start with, and some have other congenital heart trouble. But the older runners often will have coronary artery disease and arteriosclerosis. The
Yeah.
younger people are more likely to have congenital issues and hypertrophic cardiomyopathy, where you have a large heart. That used to be the commonest thing for the younger runners.
So you'd recommend an exam before you did a marathon, right?
That's what they are suggesting, yes.
Mm.
Especially for the young people, because if you have hypertrophic cardiomyopathy, you shouldn't be running. And then if you're older and you have coronary artery disease, you shouldn't be running. Right.
So Darryl, did you have a checkup before you started marathon running?
Yeah, I had let's see, about third year into marathon running, I had a stress test. That went through the EKG. So I've had those a couple of times where I was marathon running, and one of the valuable things is to wear a heart rate monitor because basically you don't want a red line, and you're getting close to redlining. So most marathon runners can complete the 26.2 miles. Comfortable heart rate is about 130. Going uphill, you probably get to 140, 145. Going downhill, you can coast to about 120. Where you start getting into problems is when your heart rate consistently goes over 145. Then you're redlining. If you get into an AFib condition, you could be 150, 160. At that point, you should stop. You're in trouble, and you're not going to run your way out of it.
You're not going to run from it.
Ooh. So you can do that with a watch now? You can do your...
Yeah, you wear the heart rate strap around your chest, and it's connecting to your runner's watch, and so you can always the best runners. Let's see, it's heart and lungs. and it's also leg muscle. But the most important thing is to run as much as your heart and lungs will give you. If you're running anaerobically, that's running when you're short of breath. Even when you're running fast and a long distance, you should be able to run at a pace where you can hold a conversation. Um, and it's like it's a good idea if you have running partners or a running team and you're talking to somebody the whole 26.2 miles. That way you don't overrun your lungs, and you wear the heart rate monitor and you don't overrun your heart. But it's your heart and lungs that get you through it.
Thanks for sharing, Darryl. Okay, let's go to the next article, please. Yeah, this is the article that recognizes that it's up to the patient to decide whether or not they want to continue. We know that sudden cardiac death during athletic events occurs. And Now, if you have hypertrophic cardiomyopathy, the doctor's going to tell you to stop running, period. Because we know that you have sudden cardiac death in those circumstances. But who's to say? You explain the risk to the patient, and you can recommend that they stop doing it. But some athletes will continue anyway, and some of them die as a consequence. I think Reginald Lewis was one of them. Because the doctor can make recommendations, but it's up to the person to accept the doctor's recommendation or not. Except, of course, if you have hypertrophic cardiomyopathy, then I think most people would accept the doctor's recommendation to stop sports, although you have exceptions to every rule, and it's up to the person to do so. Although in most athletic, they want to check you and see if you have anything first, and if but as you know, athletes in some sports uh, aren't tested, and if they are tested, they have a greater risk of having hypertrophic cardiomyopathy or having a congenital disease that can be corrected. As you know, LeBron James' son had a congenital issue that caused his cardiac arrest, which was corrected so that he's now playing basketball. So having an examination and finding out what is wrong can eliminate some of the factors that would result in sudden cardiac arrest. John Tatum?
Yeah, I've always wondered why athletes like marathon runners, basketball players running up and down a full court, when they get very, very winded and they want to rest a few minutes, they always lean forward and put their hands on the top part of their knees. Does anybody know why they lean forward to rest like that?
I don't. Any other comments or questions about this? But I think nowadays most of the university athletes undergo EKGs and other tests to be sure that they're okay. EKG is the least that they can get done, and of course, ultrasounds and other things can be done as well. Darryl?
John, Google search says people often lean forward when short of breath to improve lung capacity. So it increases your lung volume. You lean forward in a tripod position so you can get more air in.
Okay, thank you.
This next article is on stroke prevention. It's a condition that affects people who are over 50 and some under 50. And the risk factors that can be modified are listed right here. High blood pressure, air pollution, cigarette smoking, diabetes, high lipid levels, atrial fibrillation, sickle cell disease, postmenopausal hormone therapy, depression, diet and activity, weight and body fat. And uh, the other ways are aspirin, take care of your blood pressure and stop smoking, and use cholesterol-lowering modifications. And then, of course, diet and exercise. And then, of course, uh, plant-based diets and exercise, of course. So these are important for us, those of us who are over 50, to an ounce of prevention is worth a pound of cure. And if you've seen anybody with a stroke, you know you don't want to have a stroke if you can prevent it. So keeping this in mind, and if you have any signs of facial paralysis or going blind in one eye or anything like that, it's important to go to the hospital as quickly as possible. There's some articles we'll encounter which talk more about that. Any comments on this? For our age group, it's important to keep all of these things in mind. Controlling the blood pressure is something that most of us can do if we take the medications as required by the doctor, and if we monitor our blood pressure, which is critical. Taking blood pressure medicine without monitoring the blood pressure is not adequate. So everyone should have a sphygmomanometer, blood pressure recorder, so they can make sure that their blood pressure is under control. And nowadays, the pressure you want to be under is 130 over 80. Okay, let's go to the next article. This is an article that evaluates the way we handle strokes over the last 25 years. And it points out that we spent a lot of money in healthcare, but we've made a difference. And 90% of the people who have a stroke can arrive less than an hour after symptom onset, which of course was not true 20 years ago. And very few receive life-saving thrombolytics, which would dissolve the clot. Nowadays, that is clearly done because we have hospitals that are stroke hospitals, and they have the ability to give thrombolytics, which dissolve the clot and or remove the clot itself. So this is a consequence of determined efforts to make sure that if you have symptoms of a stroke, that you go to a stroke center, and that they would administer the thrombolytics, and or if you have a large vessel occlusion, take out the clot. Any comments about this? Because this is a dramatic change in the last 25 years that has gotten to the point where they used to have sometimes stroke doctors, stroke neurologists on the ambulance and other things to ensure that people who have brain attacks, as they call it, would be taken care of as urgently as possible. that we'd have stroke centers and have hospitals that will take care of people who have thrombectomy centers and so this is it's been something that has been a work in progress, but it's made a difference because now you see people come to the hospital have strokes and they leave the hospital without any disability at all. And you could see that this 96% of the population access within an hour to an ED with any acute stroke abilities. And you see people walking out of the hospital without any paralysis of any sort. This is a tremendous change from how it used to be 25 years ago. But the thing that they keep pointing out is that you have the best in California and the worst in Mississippi. It's funny how Mississippi often has the worst of everything. And the South and where our people are have the poorest results. Any comments about this interesting article about a malady that we're more subject to have than other people because of our predilection to diabetes and hypertension? Yeah, hypertension, diabetes, obesity, high cholesterol, and smoking are the factors that can be addressed.
Thought this was interesting. We are in the stroke belt.
That's right. Yes, we are. Where we are determines, where we have more of us, we have more strokes. So this is something that we need to be aware of. And most ambulances know where the stroke centers are, so they know where to take you. Betty?
Yes, I'm just thinking about a stroke. My dad passed from a stroke, but and he was at my house at the time, and I just don't answer that, John. I just don't remember any symptoms or he was just weak is all I can really remember. This was back in the 60s. So I don't remember just any specific incident or anything like that that would have made me think he had a stroke. Or he was just weak and he stayed in the bed most of the time. And eventually I think it was because he wasn't I couldn't get him to eat is why I eventually had him go to the hospital. And then they said he died from a stroke, maybe a week later, or about a week or a few days later, I think he passed. But
Yeah, things are so much different now.
yeah.
Tatum?
Yeah, my question is these strokes, the causes between diet or sedentary lifestyles, lack of exercise, what causes the increases in strokes among the elderly?
Well, I'm sorry, I didn't understand your question.
What's causing the increase in strokes? Is it bad diet?
All of the, as we mentioned, all of the things that we've been talking about, all of the things we were talking about, high cholesterol.
I'm looking for number one.
Well, hypertension is one of them, arteriosclerosis, diabetes, and then, of course, you mentioned diet and exercise, not taking your blood pressure medicine, monitoring your blood pressure, arteriosclerosis, having a our red meat diet and not having a plant-based diet. Uh, so all the things that they mentioned, we mentioned previously. Remember the 10 list that we had, all of those are responsible for stroke.
Yeah, yeah. I was just looking for the number one killer, but there's no number one.
I would think that number one would be hypertension.
Okay, thank you. That's probably the
But
answer I was looking for.
you have a list of about 15 items that contributes to it.
Right.
So,
Yeah.
but hypertension and diabetes are two of the commonest.
Thank you.
Dr. Callender, I had a question. My mom had a stroke, and I think it was as a result of her not taking uh, her medication. She had hypothyroidism, uh, and she had medication for that. And I think she missed like a couple of days of it, but was still, being active. Going below.
Hypothyroidism is not a usual cause of a stroke. Uh, of the causes of stroke, hyperthyroidism and hypothyroidism are not considered as common causes of strokes. Uh, More likely are, of course, uh, high lipid levels and high blood pressure, uh, which causes arteriosclerosis. So,
Okay. Well, I'll wipe that excuse out of my brain.
yeah, thyroid is rarely the cause of the stroke. Any other comments or anything you want to share with us about? Uh, and remember, there are two kinds of strokes. There's the ischemic stroke, which means that you got a blood clot that blocks circulation to the brain. And you have hemorrhagic strokes, which bleeding occurs and that damages the brain. And the commonest, the most malignant is the one where you have bleeding from high blood pressure, which is the most devastating. Then, of course, the ischemic stroke is the one that is more easily treated by dissolving the clot or taking it out, whereas the bleeding was the one that is associated with more likely to be associated with death. Darryl?
Jamie Foxx had an ischemic stroke, and he made a pretty good recovery after quick treatment. Sinbad had a hemorrhagic stroke, and he's struggling. He's left with a lot of deficit, numbness, paralysis.
That's why you don't see Sinbad anymore, huh?
Right.
Mm. Yeah, an ischemic stroke is treatable, much easily treated than a hemorrhagic stroke, though. The hemorrhagic stroke, though, is more associated with hypertension and far more difficult to treat. And as you mentioned, it's associated with disabling side effects. Okay, if there are not any more comments, we'll go to the next article. This is an interesting article from Helsinki that talks about what they did in China, where they used a system of using AI to make a diagnosis early and treat it. And by doing this in those circumstances, they're able to get reduced disability from strokes. This is not something that is yet used in UK or United States, but this was done in China. So down the road, it appears that AI will play a role. As a matter of fact, there's an article that we may not have a chance to get to that identifies that use of AI in the emergency room, I'm sorry, in the ambulance, was more effective than having a neurologist in the ambulance in terms of deciding how the stroke should be treated and where it should be treated and so forth. So AI is becoming more and more a tool that physicians are using to try to make earlier diagnosis and use treatment to get people to get better quickly. So that AI is becoming more and more common, and is something that is going to be really part and parcel of your medical therapy as we go on. Yes, Buchanan?
Is it a physical tool, like the Star Trek tricorder, where they scan you, or well, how do they actually employ the AI?
Well, this I'm not sure because they don't tell you about it because they use a different methodology than they do in the United States. For in the United States, though, they actually involve AI to look at the data that is accumulated. That is the symptoms, the uh, results of the CT and other things, all put together to decide on which is the best treatment for you. Uh,
Are you going to get a CT scan in an ambulance?
no, not a CT scan, but you can, not often, but they can certainly go over the symptoms and uh, but I'm not sure that there are very many ambulances you can get a CT scan in the ambulance. Darryl?
Yeah, we don't often talk about mini strokes, which aren't the typical symptoms of numbness, blurred speech, blurred vision, difficulty with speech. But the mini strokes, called TIAs, transient ischemic attacks, typically that's where you just have a small blackout, but then you recover and you're fine. And so, I had a friend that was suffering for TIAs for years, and well, he was also a drinker, drinker's blackout. So he didn't think it was anything serious, but then it led to a hemorrhagic stroke, which was brain damage.
Mm. Thank you for sharing. TIA is thought to be a forerunner of strokes. Uh, the transient ischemic attack are thought to be the forerunners, and if you have one, it's a good idea to go to the hospital and get the carotid testing and the CAT scans because a stroke may be imminent. So, thank you for sharing, Darryl. Next, this is the study we mentioned before that here they were because you asked about the how what AI were used was used in the ambulance that allowed people to be triaged and be sent to the hospital where they would be better treated. And a lot of it is related to whether or not they have symptoms that demonstrate uh, paralysis or if you have a TIA, that of course is uh, indicates that you really need to be treated. Or if you have a large vessel occlusion, which means you have paralysis, that is uh, that also can be used in the evaluation. Uh, I don't see that they do have they have web mapping. I don't see that they have CAT scans. So, uh, but it is clear that the AI did help in identifying if you had a large vessel stroke, which if you have any paralysis, that's usually large vessel. And those people would need to get to the hospital quicker, and they need thrombolysis. And with a hemorrhagic stroke, it becomes even more critical because control of the blood pressure may decrease the bleeding. So the computer modeling of the symptoms is what they use to AI to help them decide where and when, which hospital to take them to. They don't go into details as to what they used, how AI helped them decide where and when to go. But and that's a shortcoming of this. Buchanan, yes.
Yes. So you notice that someone is having those symptoms of a stroke, blurred vision, numbness of the side of the face, uh, uh, broken speech. Maybe half of their body is numb or, goes paralyzed. Um, and you're on the way to the hospital. How do they know what kind of stroke you're having without, don't they have to do a CT scan to determine what it is?
Yeah, they will have to, yes. But I guess you also, if you know what the blood pressure is, and if the blood pressure is up, then of course that's suggests it could be bleeding. If the blood pressure is normal, then you think more of a ischemic stroke. But this doesn't tell us exactly what they use in order to identify uh, what parameters the AI uses to identify where they're going to send the patient to. Did he play that?
Yes. The difference in the different hospitals, you saying send them to a hospital that, you know,
The stroke
have
center.
stroke centers. But from my experience with getting in an ambulance here lately anyway, they take you to the nearest hospital unless the nearest hospital is already capacity filled.
Well, it also depends whether they have a stroke center, because all hospitals are not stroke centers. So if you have a stroke, they take you to a stroke center.
Oh, okay. So if they
They wouldn't just
look
take
at
you.
you and
They
realize you
wouldn't.
have,
They wouldn't just take you to any hospital. They take you to a hospital that has a stroke center.
okay, okay,
And each hospital is designated as a stroke center or not.
okay. That's for a patient that they feel are having a stroke, but they see I have this having a
Yeah, right.
stroke.
You know if they're having a stroke,
Okay,
right?
okay,
And so they would go to a stroke center. Now,
okay,
if they weren't having a stroke, then they'd go to any hospital. But
okay.
but for a stroke, you go to stroke center. And that's what has changed over the last 25 years, is that we now have stroke centers. Uh, okay. Okay, I think that we may have time for one more article. No, we don't. No, we have to. No, it's 10:30, so I guess we better close. Thank you for being with us today, and thank you for all the feedback we got. Uh, any closing comments or questions before we say goodbye for another day?
Happy Father's Day to everybody, all the dads on the line.
Oh, thank you.